around the liver. So I think this patient is having pretty bad hemolysis for that for that pool 1 year, to which she has received a total of 13 transfusion. And then yes, they have hemolysis probably, and then they don't have petechia. It means the their platelets probably is not too low. Even if it's low, we'll see in the FUBA picture, but it's not too low, because to have petechia, you have to have like severe thrombocytopenia. Another thing, the vitals, that patient had tachypnea, yeah, because of anemia, and because we've already been told patient is a DIB. So can I see the respiratory system exam? I think there was something, was it, it was dial percussion note, I think. There was somewhere there was a dial percussion note. I think it's the next slide. Yeah, yeah. So yes. So the dial percussion note, it seems we're on both sides, but the one side was more than the other. And you asked the question: is this an effusion? And yes, probably it's an FC, because some people, it's not the same how I examine the patient. Someone, Seba, is maybe better than me, and some people will need to hear Tony Dial to say fusion, and when they hear Dial, they say, okay, that's a consolidation. But I don't go that way. I personally, it's hard to tell them apart, if I can say. But perfusion on the related to it, when I see this, it means probably it's not a consolidation, that it is a perfusion, and the reduced vocal resonance. Yeah, so the other things, as we thought initially, the abdominal distension is probably due to an enlarged viscous, and we're told this patient has splenomegaly on the abdominal exam. The positive shift in dullness means they have ascites, but I think it is not the ascites that's causing DIB in this patient. It's the anemia, because this ascites is moderate ascites, positive shift in dullness. So everything sits in the respective area, and we come back. We say, now, what is the thing that can explain all this? We say Mara Rush does that spares the nasal alveolar. This is lupus, and can lupus cause hemolytic anemia? Yes, the answer is yes. And this hemolytic anemia has to be, I think, if you send the markers for autoimmune hemolysis, they come back positive. So I think we'll send them and we'll see. So because lupus is an autoimmune disease, if you have one autoimmune disease, expect to have another one. And these patients have lupus, so they can have hemolytic anemia. And the hemolysis can explain the jaundice, can explain the recurrent blood transfusion, can explain even the splenomegaly. Because, splenomegaly has a lot of differential diagnoses. They say it's more than 100. So the easy way, if you see splenomegaly, is to ask what years that the patient has. And then you realize, okay, they have lupus, probably, and they have hemolysis. So maybe the spleen is hyperfunctioning to clear the damaged RBC from the hemolyzed RBCs, to clear them out. So yeah, I think that can also be explained. Pleural yes, serositis. So pleural and the ascites, yeah, from serositis can be explained by, again, lupus. Plus, the patient is a young female. As we said, bad luck. This is pretty bad luck, but it's the age for lupus, young females. And yeah, so I think I'm there. I'll have to look at the labs, but at the end I must send an ANA with the subtypes, the dsDNA, and Smith, and etc. Back to you, Saber.
Joseph, can you summarize the case for those who joined late?
Yeah, so Seba is presenting a very nice case of a 22-year-old female who presented with a general body weakness for 1 year, abdominal distension for 4 months, and difficulty in breathing for 2 months. So other symptoms in the HPI included easy fatigue, palpitations, patient reported fever, low grade that went away on with paracetamol. There is a positive history of multiple blood transfusion, up to 13 transfusion in 1 year. And patient also reported airy satiety, loss of appetite, difficulty in breathing on exertion, a mild cough, and also they have a rash that on exam, Seba is telling us it's a Mara rash, which spares the nasolabial fold. And also patient has also infertility for 2 years. The exam is what I was discussing here. They have a Mara rash. Patient is pale, has jaundice, but no petechia. Respiratory rate is tachypnic at 22, I think. And on respiratory system exam, the positive findings include dial percussion note, right more than left, reduced vocal, tactile vocal parameters, and abdomen, she has splenomegaly, as you see in this slide, and a positive shifting diurness. Yeah, that's it.
So thank you, Dr. Joseph. So moving on to the part of investigation. So a patient did a number of CBCs. So I managed to put at least 4 different CBCs, which almost entail the same picture. So we can see a striking feature starting from the WBC. WBC was low. Then RBC levels were also low. HB was low. RDW was elevated. Even platelets were also significantly low. The findings which were consistently across all the full bed picture that this patient did. So reticulocyte count was done to this patient in a number of different occasions. And it was also, the absolute number was consistently lower. So even a corrected reticulocyte count was also very low in comparison to the normal. So total bilirubin. So a number of total bilirubin were done. So most of them were across the upper normal limits. Direct bilirubin was normal. So markers of intravascular hemolysis such as LDH and uric acid levels were also normal to these patients. Vitamin B level were normal and folate levels were normal. So other investigations, renal function test and electrolytes were normal. The liver enzymes were normal. Lipid profile was normal to these patients. Serology, which is HIV, hepatitis B and C, were negative to these patients. ESR was elevated around 30. Serum ADA was 6.8, and CRP was 11.2. So peripheral blood smear was done to this patient, which had features of pancytopenia, together with presence of teardrop cells, carrying possibility of could be secondary to an infectious or an inflammatory process. So patient went ahead and did trephant biopsy of the bone marrow, which revealed marked fibrosis with islands of hematopoietic activity and pockets of clumped megakaryocytes, together with an increased spindle-like cells with abundant reticulin fibers. Conclusions was myelofibrosis. So in terms of imaging, chest radiography revealed a bilateral pleural effusion in this patient, and abdominal ultrasound was done, which revealed splenomegaly and ascites.
Yeah, thank you, Seba. This is a cool case, I can say. And again, I emphasize you guys who sit in that room listening to the grand rounds. You are so lucky because I missed this. So let's see. What we are seeing in this picture is a pancytopenia. And this complicates the case, I can say. It makes me more difficult to tackle this case, but I will try. So when you see pancytopenia in a patient, your answer is it is more likely this is the problem of the marrow than the system. I say than because there are other systemic causes that can cause also pancytopenia. So for me, when I think of pancytopenia, my approach, I think that I learned in the NEJM, they say, you think of 4 S's. I think of 4 S's. And these 4 S's can be a space occupying region in the marrow, a problem with a stem cell problem. And then you have, these are meds, yes, substance, the S is substance. And then lastly, you can have systemic disease. So you start with a space occupying region in the bone marrow. Everyone knows this, but like malignancy. So think of leukemias. A lot of WBC can go and pack themselves in the bone marrow and cause the cells to lack space, and then you have pancytopenia. Lots of malignancy there. I mean, leukemia, lymphoma, etc. That you know them, and but you can have a non-malignant stuff that can go and pack themselves again in the bone marrow. Remember presenting a case of Gaucher's disease when I was a resident, and then the patient had pancytopenia. So maybe the cells that infiltrating the marrow, they are not malignant, but they are molecules, by the way, and other stuff like sarcoidosis, for example, and others. And then you come to substances. So you know, patients who are taking a lot of alcohol, they can have pancytopenia, but this patient did take alcohol. And other medication like I think methotrexate, for example, or other cancer medications. If there's a problem with the stem cell, you can have an autoimmune disease of the stem cells, for example, in a plastic anemia, and you have pancytopenia. Oh, I forgot some other things there, but yeah, systemic diseases, I think, is the issue here. Why? Because this patient did a bone marrow biopsy, and we're not told of any suspicion of cancer, but we're told of myelofibrosis. So I wonder, is myelofibrosis on its own cause, can myelofibrosis on its own explain all the picture of this disease? I find it hard. I understand that myelofibrosis is among the so-called, I think, I forgot the name, but the group includes things like not MDS, things like CML, the myelofibrosis itself. There are 4 diseases in that group. I'll come to them later, but I don't think myelofibrosis will explain this picture, like the rash and everything else. It's usually the pancytopenia on its own. So maybe it's a disease sitting separately to what we are discussing. Or at the end, I have to learn probably lupus presents with myelofibrosis. I don't know. But systemic diseases that can present with pancytopenia, anything that causes splenomegaly can cause any systemic disease cause splenomegaly can cause pancytopenia. And lupus SLE can cause splenomegaly. So does the pancytopenia we are seeing here is just a sequestration effect? Probably, but there are other systemic diseases which I don't see that this case brings them in. Things like hypothyroidism or rare diseases like HLH. It's not, the pictures doesn't go with that. So I'll pause and see, but I think I'll stick with the lupus. Lupus can present with a pancytopenia, but the myelofibrosis, I'm not sure if it's part of that picture or it's something else. But myelofibrosis on its own doesn't explain other autopsy. Deletic, yeah, Seba is very intelligent. They told us he used the name. I don't know what do you say, but I think you mean the corrected. If you have anemia and letic, you don't have to depend on the leukocyte count on itself. You have to do a calculation. I've forgotten it. It's so long. I think it's called RPI, reticulocyte production index. There is a division you divide by the hematocrit, and you get you see it's important. It can tell you, although the marrow is down, but because of anemia, you're seeing it down, but it's hyper producing. I think somebody did that and he realized this it's an underproducing marrow, and it's because of that myelofibrosis. What else? So yes, the bilirubin is important because what I saw the picture, I think it was 19. I don't remember the direct, but it's a picture that shows it's an indirect hyperbilirubinemia. Still saying that this is a product of here. So because 7.6 times 2 is like 14, 15, and this is 19, is more than half. It means this is a indirect hyperbilirubinemia due to hemolysis. Plus the LDH is also saying the same thing. So an ESR of 13, a 22-year-old, slightly elevated, but remember, lupus tends to elevate more of the CRP than ESR. I think I'm getting that right. But if I'm getting wrong, you tell me at the end. Which is the reason in lupus we tend to do them both. It's important. What we are told in the marrow, they saw stuff, but they also saw teardrop cells. Teardrop cells, it means the marrow is crying. There is a peripheral disease there, making the marrow to hyper function and cry, so producing tear. That's sort of how I memorize it. Yeah, so still, I think this case shouts lupus. I'm not sure if lupus should have myelofibrosis in the bone marrow, but myelofibrosis can sit on its own, and lupus still can be there. Myelofibrosis wouldn't explain hemolysis, for example. It can explain pancytopenia, but not hemolysis. So yeah, I think I'm there. I have to see where do they meet. I think we should continue.
So autoimmune profile was done to this patient was ANA positive. Also, further assessment of the calf was done, which sputum for gene expert came out to be negative.
Yeah. So ANA is important. They say you send an ANA. If you an ANA is positive in patients who are not sick, like 1 out of 5 of the population. Okay, that's the population in the West. I don't know in the Africa, but I don't think it would be like that much different. They will be positive for ANA, and as the number goes up, which is why you have to send a quantitative. They bring you the number. They say 1 ratio, maybe 3,000. You say, okay, no, this is too high. But if they say 1 ratio 40, 1 ratio 80, you question yourself. But in the patient who has every symptom like this and the ANA is positive, you also send the subtypes, especially the double-stranded and anti-Smith, and if they're positive, it says to be a lupus. Still, I don't know the relationship of lupus and myelofibrosis. Maybe myelofibrosis was a separate disease that this patient had.
So double-stranded DNA and Smith were equivocal to this patient. Anna profile with an equivocal double-stranded DNA and Smith.
And by equivocal, you mean like in between?
Yes, they can't really tell if it's a negative or it's.
Still, I'll go with lupus. Yeah, that's my diagnosis.
Yes,
Thank you, Dr.
Can
Joseph.
I move the slides?
Yes, doctor. Yes, so our final diagnosis to this patient, we came up with systemic lupus erythematosus with presenting with an autoimmune myelofibrosis. So in terms of clinical presentation, the initial presentation was very vague. Patient presented with symptoms of anemia with no any other symptoms suggestive of one disease for more than 10 months. So the other symptoms like the abdominal distension, the difficulty in breathing, and even the facial rash came on very late in the course of the disease. So that makes the presentation of a very atypical presentation and a diagnostic challenge on how these patients are initially presented. So in the early tenure of the disease of this patient, she was actually managed as the patient with an hemolytic anemia. So despite receiving a number of blood transfusion and so forth, the patient did not get any improvement at all. So until late on, that is when patients started presenting with fever, serositis, that is a presence of ascites, presence of pleural effusion, which are all in keeping with serositis, then appearance of the facial rash. These were all the features now led us to make the diagnosis of systemic lupus, which presented with a very rare complication of systemic lupus, that is autoimmune myelofibrosis. So just some few teaching points in the bone marrow fibrosis. So it's a rare condition that is associated, can be caused by a number of conditions. So the most common cause of bone marrow fibrosis is neoplasms, such as the CML autoimmune, CML together with the other acute form of leukemias. Then it could be followed by infections. Then down on the list is autoimmune diseases like systemic lupus and Sjogren's syndrome. So autoimmune myelofibrosis is a non-malignant bone marrow fibrosis which occurs in the presence or absence of a defined systemic autoimmune diseases. So in the early course of the disease, this patient did not have a well-defined autoimmune disease, which was SLE. But later on, patients came up to develop a very typical presentation of SLE. So something peculiar about this case, most of the case reports that we were able to see reported the association when the patient already has a well-defined SLE. But at this particular point, it's like the autoimmune myelofibrosis was the first presentation of SLE to this patient. So although myelofibrosis is the prominent feature in hematologic neoplasms, it's rarely observed in autoimmune disorders, as I've said previously. So unlike primary myelofibrosis, in which it is usually idiopathic, you can't find a specific etiology, such as there is not any infectious process, no any neoplasm. Patient is negative for most of the common autoimmune diseases. Secondary myelofibrosis is usually due to identifiable causes like SLE. So this is the rare disease, accounting for almost 10 to 15%. So although SLE is the common cause of autoimmune myelofibrosis, it rarely causes bone myelofibrosis. Only a few cases have been reported so far from when we tried to consult literature. So most of the cases of autoimmune myelofibrosis usually occur in a younger female patients with a known history of SLE. And the typical presentation, patients will present with features of anemia together with splenomegaly. So in terms of diagnosis of the disease, usually a clinical picture can help you to determine if the patient is having features which are suggestive of pancytopenia with the possibility of bone marrow failure. But to be very sure that you're dealing with autoimmune myelofibrosis, then a Trephine bone marrow biopsy has to be done, which usually reveals presence of abundant reticulin fibers, together with no or few collagen fibers in the absence of megakaryocyte dysplasia, which is usually a typical characteristic of autoimmune myelofibrosis. So this is just a histological slides which shows autoimmune myelofibrosis. So in the right side, you can see a photomicrography which shows reticulin, which are like silver stains in a patient, from a patient who had myelofibrosis. So they're usually diffuse and dense, together with extensive increased numbers of reticulin. So presence of this reticulin or silver-like stain is usually pathognomonic for myelofibrosis. So it's usually important to be able to differentiate and identify what is the cause of this myelofibrosis. Is it due to an autoimmune disease, or is it due to a neoplastic disease? Because management now will be tailored depending on the particular cause. If it's autoimmune, then the patient will follow treatment of that particular autoimmune disease. Then if it's neoplasm, patients will be managed. Management will entirely depend on the primary diagnosis of that particular cause of this myelofibrosis. So bone marrow failure, which is usually the gold standard, is performing a bone marrow biopsy. And bone marrow biopsy, usually it's important because it grades the severity of autoimmune, of myelofibrosis. So treatment of autoimmune myelofibrosis is purely depends on the primary underlying etiology. In this particular patient, the primary underlying etiology was systemic lupus. So patient was kept on systemic lupus management. So we started with a pulse therapy to this patient. We passed the patient with high dose corticosteroid. We kept the patient on the course of IV methylprednisolone for 3 days. Then later on, we introduced oral prednisolone in a tapering fashion, starting from the dose of 1 milligram per kg up to 6 weeks. Then we kept the patient on hydroxychloroquine 200 milligram BD. So all of this will be tailored depending on the disease activity for SLE, which is usually we score it using the SLAD, which is SLE Disease Activity Index, with the aim being less than 4, which is the low disease activity. Together with all of this, the patient has to be kept on general measures which are important to all patients with systemic lupus, which is sun protection. If the patient was with a previous smoker, then smoking cessation, important vaccinations, because these patients will be kept on a long run of these immunosuppressive drugs. So it's important to be vaccinated to reduce the incidence of infections. So this is how we were able to manage our patients, as I've said previously. So at one particular point in time, patient had very low neutrophil counts, which was less than 0.5. So the patient was kept on prophylactic drugs, which is prophylactic antibiotic, prophylactic antivirals, and antivirals. So overall prognosis of autoimmune myelofibrosis, patients tend to have a good prognosis, with 85% of the patients will have a clinical remission at some point in time. So a patient, as soon as we introduce the regimen, patient has been having features of anemia completely disappeared in these patients, and patient had a very good hemoglobin level. The current hemoglobin level of this patient is around 10 to 11, with no any symptoms of serositis, and symptoms of anemia have completely disappeared in these patients. So cases of relapse also have been reported, although it's almost less than 15%. And usually patients who present with severe myelofibrosis at first are the ones which are more associated with an increased extent of relapse in comparison to those who had low-grade myelofibrosis. Yes, this was today's case, Dr. Joseph.
Yeah, thank you very much. A very good teaching point. So yeah, pretty nice learning points for me. So I usually knew myelofibrosis is part of myeloproliferative disorders that I've blanked initially. So you're teaching me a new thing that you can have autoimmune myelofibrosis. This is pretty cool for me. Thank you very much. Thank you, the chat. I was not looking at them. I could have had a lot of help from it, but you guys are pretty much amazing. Everyone who was contributing, we like this. Keeps you engaged. So yeah, back to you, Seb.
Yeah, so I see a hand here. Please welcome.
Thank you very much. I have a question and a comment. Can I proceed?
Yes, please. Yes, you can proceed.
Yes. All right. My question is, why did you decide to give hydroxychloroquine 200 BD and not only OD? Because as we see with the anti-dsDNA of equivocal, so the disease was not that active at that point. So did the myelofibrosis like necessitating more hydroxychloroquine, and we know the side effects of hydroxychloroquine? And if at all you want to give a high dose like 400 per day, why did you decide to divide it, not OD?
Yes, you said you also had a comment. Maybe you can finish it then.
All right, no problem. So my comment in this patient who presented also with difficulty in breathing, now I didn't see the chest X-ray if the effusion was that massive to cause difficulty in breathing. And we know the antiphospholipid syndrome, which usually overlaps SLE. So 10 to 30% of patients with SLE, they may have antiphospholipid syndrome, which can cause thrombosis and like pulmonary embolism. So I would suggest if we could do also CTPA and rule out pulmonary embolism in this patient, because also APS is associated with thrombocytopenia and hemolytic anemia. So yeah, I thought it's important also to think of antiphospholipid syndrome.
Thank you very much for the questions and comments. Maybe Seba, if you have any responses about the dosage and any comments. I think Joseph, you already talked about. You already made some theories on maybe what could explain the difficulty in breathing. But any other thoughts in response to the comments?
Yes, thank you very much, Hada, for your comments. Yes, with regard to the possibility of antiphospholipid syndrome, yes, with SLE, yes, up to 30% of patients may have a coexistence together. Although we didn't manage to do the lupus anticoagulants or the anti-cardiolipin to these patients, but maybe the possibility of having being infertile for 2 or more years could be suggest maybe, but we couldn't be very sure until at least we have an evidence of either lupus anticoagulants or the anti-cardiolipin. With regard to pulmonary embolism in these patients, so the WARS score was a low risk, and D-dimers levels were done and were normal to these patients. So we didn't have any necessity of doing a pulmonary CT angiograph to this patient. And
Maybe I should just comment here with D-dimer. So we know that
yes,
D-dimer is not sensitive, but it's specific, right? So if it's positive, it doesn't mean anything. But if it's negative, it rules out pulmonary embolism.
yes, thank you.
And with
So,
regards to the doses.
so with regard to the dose of hydroxychloroquine, we started this patient on a dose of 200 milligram BD, because the SLAD activity in these patients will, although yes, the anti-double stranded was equivalent in this patient, but this patient had features were hematological malignants. I mean, features which were in keeping with hematological presentation, serositis, together with other presence of constitutional symptoms. Although we didn't get anti-double-stranded DNA or anti-Smith DNA, possibly we started the patient 200 milligram BD. So with regard to the points that you said, maybe we take it positively, and maybe we can improve next time.
Also, so with regards to the question on pulmonary embolism, ruling out pulmonary embolism, I think yes, Adao, you commented something there, but given the fact that they did a Wells score and it was low probability, then of course you cannot go ahead and do a CTPA. So if it was high probability, you go straight to CTPA. So if it's low probability and you do D-dimer not elevated, then there is no need of proceeding to CTPA. I also see a hand from Rajabu, and then I'll come back to Hadao.
Okay, thank you. Thank you, Dr. Sebastian, for a very nice presentation, and also Dr. Joseph. So my in point was on, it was important for us to do genetics, such as to do the JAK genetics genes, especially in this patient, because now we think, of course, it's a secondary myelofibrosis, of which we are calling autoimmune. but there's also a component because it can also be a primary, though with the age doesn't tell, because most of time myofibrosis, especially the primary one, occur at the age of 6 and above. But the genetic study could have helped us to rule out the possibility of 40 of the primary myofibrosis. And also I have another input on the bone marrow. So the bone marrow specifically doesn't help us to give a diagnosis of the myofibrosis, because most of the myeloproliferative neoplasia, most of them, they have that specific presentation of the fibrosis in there, including the essential thrombocytosis, the polycythemia, all of them. But there are other investigations you can do to rule out those other myeloproliferative neoplasia. Then we can come and say, okay, this probably is myofibrosis. Thank you.
Thank you very much. Oh, back to Hadawa. I see you still have your hand raised. Or maybe you didn't lower your hand initially. Hadawa, are you still there?
Yes, sorry, I just didn't lower it. I don't have further questions.
Okay, no problem. And I was trying to check here just to make sure about the doses. I see the dose of hydroxychloroquine on SLE is in the same range, actually 2 to 400 milligrams per day, either as a single dose or in two divided doses. So I think the team was had a justification for doing that 2 to 400 per day as a single dose or in two divided doses. Yeah, you see the crowd was very active today. People in the chat, many messages. I hope, Joseph, you checked the messages later just to make sure there are some comments to help you there. I do not see any other hand raised. I'm not sure if there is any other burning issue at the moment because we are past the hour.
Just to acknowledge Dr. Rajabu's comments. Yes, so on our wish list, we had a wish list of the important investigations which we couldn't do, but still were important to these patients. So as Dr. Rajabu said, so molecular studies to look for the JAK2 mutation and the MPL mutations, and also some immunohistochemistry staining, so that you can be able to rule out any sort of myelofibrosis mimic, apart from the one which could be, as we have attributed, could be caused by an autoimmune disease.
Thank you very much, Sebastian, for taking your time to prepare this presentation, and Joseph for discussing. I'm not sure if there is anything else from any of you before we close. Joseph, anything?
Good night.
Okay, if there is nothing else, good night, everyone, and see you next weekend.
Good night, all.